Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Sushil Tahlani. Sir is MBBS, MD, DVND, dermatologist at PD Hinduja Hospital and Dr. Tahlani's Clinic, Mumbai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is clinical significance of examination of nails. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you for the kind introduction and thanks for having me as a speaker. Good evening, friends. I'm sure when we entered the wards in the second year MBBS, we were first taught to examine the nails with importance of what is the significance of pallor, cyanosis, clubbing, koilonychia, etc. But does the examination nail begin and end there? No. So here we are. I'm here to tell you what all things can we get through a proper examination of the nails. So I'll give you a small introduction on the topic. Then we'll discuss the anatomy and functions in brief. Then we'll discuss the various signs that we should look for when we examine the nails. And I'll show a few clinical scenarios of involvement of nails in systemic diseases, nails in some dermatological diseases, and some tips and takeaways. So nail is actually modified stratum corneum. It protects the terminal part of the digits. Just imagine if you were to pick up a fine object like a needle from the floor, would you be able to do it without a nail? So it does help us picking up fine objects. And what's interesting to know is that once the fingernail is removed, it needs 4 to 6 months to grow from the matrix to the tip of the nail. And it takes 12 to 18 months for the toenail to do the same. And that's why when we trim our nails, we realize that we have to trim the fingernails more often than the toenails. And then nails do change in health as well as disease. Nails do help us solve medical legal cases in a few cases. And nails have been a neglected appendage. So when we examine the nails, we should be having good light, a magnifying glass, and we should examine all the nails, and we should look for the size of the nails, shape of the nails, color, the nail bed, the proximal nail fold, the lateral nail fold, and the cuticle. And in case of women, they should be requested to remove the nail cosmetics so that you can examine the nail properly. And when we examine the nails and if we get some clues about the disease, sometimes examining the skin will give us more information about the diagnosis. And in case of feet, some of the changes in the toenails can be because of the defective footwear. So you have to see the footwear. And you have to examine the space underneath the nail, subungual space, and the pulp of the digit. And when we do a clinical examination, either we look at the nail surface changes. So we have those transverse lines called Bowes lines. We have nails which come off from the matrix, from the proximal end, and they are shed, onychometasis. Then we all know about how the surface can show pitting, and the entire nail can be very brittle and fragile, onychorhexis. And the nail surface can be opaque and rough like a sandpaper, that is trachonychia. And we also see longitudinal furrows and grooves and ridges. When we look at the change in the shape and size, you can have nails which can be absent, or these nails can be small, micronychia or anonychia. And we all know the spoon-shaped nails. We know the clubbing. A pincer nail is a nail that narrows down from the matrix towards the tip because of progressive increase in transverse curvature. And we can have nail plate which can be thick and very convex, pachyonychia and onychographosis. Then you can see some changes in the color other than the pallor. So nails can be opaque and white. They can be dark, chromonychia. They can be reddish, that is erythronychia. And you can have the difference between the nail plate and nail bed adhesion. Normally the two are adherent, that's why, and nail plate is transparent. That's why when you press the nail plate, the capillaries are squeezed and you see release in pinkness. When you release, the pinkness comes back. So sometimes the nail plate and nail bed can get separated, that is onycholysis, and you can have a debris of stratum corneum collecting between the nail plate and nail bed, that's a subungual hyperkeratosis. Then you should also be looking at the tissue around the nail. The nail fold capillaries are very useful in informing us about connective tissue diseases. We'd also look at the proximal nail fold and lateral nail folds. Now, some examples of how the nails get changed in systemic diseases. We all know about clubbing, but clubbing does not always tell us about a systemic disease related to lungs, etc. You can have clubbing as a congenital. This person was absolutely healthy, and clubbing in this person's case was congenital. And we have to remember the nails can be overcurved, but we have to look at the angle between the proximal nail fold and the nail plate. And if that's obliterated, we call it clubbing. In contrast, when you see a single nail getting affected, it may be a pseudo clubbing, it may be a growth or hypertrophy of tissue underneath the nail plate in the nail bed, which is pushing the nail plate up. So this is not true clubbing. Then we all know about koilonychia, and we straight away correlate this with iron deficiency, but not necessarily. It's very uncommon for iron deficiency to cause koilonychia. You can have congenital koilonychia, idiopathic koilonychia, so you should not straight away give them iron. Looking at this, we have to remember a lot of us have habit tics and we have stress. And there are people who use index finger to keep picking on the proximal nail fold, that is over here. And underneath that is the nail matrix, so that causes regular intermittent ridging and denting of the center, and also increase in melanocytic activity of the nail matrix. In addition, this person has also been biting the nails, so you can see nails which are shorter. So this is a habit tic, which may be a simple habit tic, or it could be a manifestation of some psychological disorder. One clue that you should remember, whenever they have played around with the nails, the lunula, which is the distal end of the matrix, as you see through the nail plate, which is translucent, the lunula gets bigger. Normally, lunula is not so big. So this will tell you that the person has been fidgeting with the proximal nail fold. There's uncommon growth over here, which is Conan's tumor. But looking at this straight away, I could diagnose this person as having tuberous sclerosis, one of the neurocutaneous diseases, which can lead to a growth of lesions on the face, on the nail folds, and you can have extension in the brain meninges as also on the retina. And Means lines were typically, when I said medico-legal, this could be manifestation of arsenic poisoning. If somebody's been given arsenic on the sly, you will know, and you'll also know from the distance of this from the nail matrix that probably this poisoning happened about 3 or 4 months ago. But you can have similar lines in chronic renal diseases. You can have in uncontrolled diabetes. So it's not necessarily arsenic. Means lines could indicate impaired health of various organs of the body. Then we all have patients who come and say, they bring their kids and they say, well, doctor, there's a line here on all the nails. So you can be a good medical detective and you can ask them, did this person, this your child have, the child have hand, foot and mouth disease? Probably he or she had, and probably that hand and foot and mouth disease happened about 2 months ago. And they look at you with bewilderment. So this is a time when some illness will reduce the growth of the nail. So there's a groove, and after they recover, that groove gets pushed out. That's called Bose lines. Then yellow nails could be single yellow nail because of local disease, or it could be a manifestation of chronic diseases or old age. Nails growing slowly, getting thicker and difficult to trim. And this is seen in renal diseases and in liver diseases. This is so-called half and half nail. Cuticle is obliterated. The proximal half of the nail is opaque and white, and there's erythema on the distal part. This is a half and half nail. Then, of course, nails are affected in many dermatological diseases. The commonest ones are the fungal infections. In fungal infections, typically the fungus invades from the distal and lateral edges. So you'll see opacity and lysis of the nail plate and nail bed junction, which then moves progressively towards the proximal end. There's a distal and lateral subungual onychomycosis. more progressed in this digit. And here the fungus is invaded from the proximal end and come out underneath the nail. There's a proximal subungual onychomycosis. When you see this, sometimes you should suspect immunocompromised person, including HIV. In contrast, there are people in old age because of tight shoes or poor peripheral circulation because of diabetes and arteriosclerosis and tight shoes, trauma, all that can cause invasion of one nail and the toe, and that one nail on the toe is usually a non-dermatophyte mold and not dermatophytic fungal infection. Single nail. And this, in contrast to what we popularly believe, is not candidiasis. This is because of misuse and use of water, all this use of detergents and soaps, which will melt the cuticle, which is a seal which keeps the proximal nail fold intact. Once the seal is broken, the proximal nail fold is exposed, things go underneath. There's a gap you can demonstrate with a paper, clean paper. And whenever they put hands in soap, water, vegetable juices, fruits, all that trickles inside and gets trapped inside. That causes inflammation of the proximal nail fold, and therefore you see rolling of the border, and you see inflammation which goes to the matrix. And since the matrix is affected, the shape of matrix gets affected, so the nail plate is secondarily damaged and becomes changed in color and shape. So we have to treat this part. There's a chronic paronychia. Then we all know pitting and psoriasis. Those are irregular, large pits, not in all the nails. But pitting does not always mean psoriasis. You have to examine the skin. Typically, if there's nothing on the skin, but if the patient has distal onycholysis with a salmon band next to it, that is more or less pathognomonic for psoriasis even before the skin gets affected. And psoriasis can go to the extreme of damaging nails in such a way that they find it difficult to trim, they find it difficult to wear shoes. This is gross onychographosis, and all the changes with lesions of psoriasis on the skin, adjoining part of the skin also here. And this is an extreme case of total nail dystrophy caused by psoriasis, but you can have similar picture in some cases of fungal infections also. So it does not mean psoriasis all the time. So you have to do mycologic studies, but you have to suspect from the pattern. And when you have psoriasis, as I told you, this could be sometimes seen more commonly with psoriatic arthritis. So this child who's only 6 years old has nail involvement, nothing on the skin, and psoriatic arthritis involving the distal interphalangeal joints. This will, then we have to see that, as I told you, when you examine, sometimes the nail plate is completely lost. This is anonychia. You see a large erosion, painful, and you see lesions of lichen planus, atrophic lichen planus. So this was an unfortunate person with extreme pain, could not walk, could not wear footwear. If the lesions go to the plantar aspect, they are bedridden until you treat them. And one thing that you see very commonly in the ingrown nails, most commonly toenails, in ingrown toenails, the nail plate, lateral edge of the nail plate pierces the nail groove, which is underneath the lateral nail fold, and that piercing causes extreme pain and inflammation. Inflammation can increase further, can cause hypertrophic granulation tissue, and then can lead to fibrosis. So these are various phases of ingrown nails. The most common cause of ingrown nail is wearing tight shoes, and when people are in city like Mumbai, ambitious, they don't remove their shoes for 14 hours. Inside they're sweating, the skin becomes soft. If the shoes are pointed, there's a pressure of the shoe onto the nail fold, which comes in close contact with the nail plate, and nail plate pierces the soft nail fold and goes underneath. So this is one reason, common reason. Second reason is when people trim the nails in a curvilinear fashion, and beauticians in their wisdom cut the edges very short. They create a point here, and that point is more likely to pierce than the entire nail plate. I'm sorry. Then we have commonly warts growing around and underneath the nail underneath the nail, but very rarely in the nail bed and never in the nail matrix. And this is a challenging scenario. This is a warts, human papilloma virus. When you see multiple warts, you have to be sure that if the patient is beyond the age of 40, these warts can have oncogenic strains, human papilloma virus. And I have picked up few cases of squamous cell carcinoma due to HPV. So long-lasting, multiple, and beyond a certain age, be sure that you're not dealing with change of the verrucae into squamous cell carcinoma. And when you see in children multiple fingers getting affected, you have to look for a history of nail biting because they bite one nail with warts, they bite the next nail, and they're inoculating the virus from one place to another place. And there's an unusual presentation of wart in the proximal nail fold underneath. So when you have nail fold, it's sitting on the nail matrix which gets suppressed. So that causes a denting of the nail plate. In contrast, if there's something underneath the nail plate, nail matrix, and not the nail fold, the nail plate would go show bulging. This is how you get clues. And of course, many times the patients come and show you all these nails which are opaque, thick, and difficult to cut. And if the person is bedridden and the nails get curved, this part can touch the nail pulp, the digit pulp, and cause ulcers. This is onychogryphosis, thickened nail plate. This is extreme onychogryphosis on one of my patients. He had lichen planus. I treated everything, but he said, "Doctor, what about this? If there's nothing that works, you have to remove the nail completely and destroy the matrix so that the person can be without the nail. The nail blade will develop thick stratum corneum, which is pseudo nail. Sometimes they accept it better than such a nail." And so onychography is not a diagnosis. This is a sign, and you can have dermatological conditions, you can have regional conditions, general conditions, infectious causes, and miscellaneous causes of onychographosis. Many times people go on the social media and they come to you saying that, "Doctor, I read that somebody had such a band and that was nothing but a melanoma which was missed." So they come with a longitudinal melanonychia, which on a part of world, brown skin, can be normal. So when you see lines which are uniform, parallel to each other, no broken lines, no nail plate damage, no fraying, no divergence or convergence, no variability in the color, and nothing spreading onto the adjoining skin. That is a benign thing. So you have to reassure them and don't send them straight away for a biopsy. And this is a pseudo Hutchinson sign. This part of nail fold is translucent. So the nail matrix color is seen through it, and that's not extension into the skin. In contrast, there's a patient who accompanied a relative and said, "Doctor, since I'm here, why don't you have a look at it?" And what he had was a nail unit melanoma, and he was comfortable about it. So here you can see along with the ridges, you can see pigment going onto the skin, irregular fashion. You have to diagnose it early before a lymph node gets affected. And if there is no involvement of the bone, you can just remove the entire nail unit and do a full thickness graft. Even the digit can be preserved if you pick it up early. And there's a patient, you can see that maybe there's nothing here, but you can see a slight pinkness on this part. What was striking was that the patient had extreme amount of pain there. There's a glomus tumor which originates mainly from the nail matrix, but sometimes from nail bed. And it causes extreme amount of pain, and the only definitive answer is a surgery. And this is another change in the glomus tumor, extreme amount of pain, and it is called the nail tube split, and it's got tented because the glomus is pushing the matrix up. So when we diagnose, most of the times, as I showed, diagnosis on clinical features, which you have to learn, and sometimes you have to hunch. So I was in European Academy of Dermatology meeting, and they said dermatology is the science of think and blink. Sometimes you have seen over a period of years and decades, many cases, and those images stored. When you see the next patient, the images are immediately matched. That becomes a diagnosis in a blink. But you cannot go for that spot diagnosis. You have to then think and cross-check and be sure that that's not a wrong diagnosis. So you have to have a hunch. Then sometimes you have to use devices like dermatoscope or dermoscope, fungus by scraping the subungual debris or taking nail plate clipping, or you can do a biopsy in some conditions to diagnose more accurately, and imaging also may be needed. I'll just show you. There's a single nail involvement in a person. We are not very sure, but if you see, they say this is a ruinous appearance. The nail plate is lifted and there's a ruinous appearance because of the keratinous material underneath. This is the same patient, a different view, nothing anywhere else on the body. Now, if you have to treat this as a fungus infection, the antifungals topically will never work. You have to give a systemic drug, and it's a 12 weeks course. And you can't be very casual about giving somebody 12 weeks course without being sure about the diagnosis. So you do a dermatoscope, and that gives you a typical ruinous appearance, which clinches the diagnosis. But in some of these cases, the patient still say, "Doctor, I'm not very sure." So that was one thing that you do, but you can do mycologic tests. But if you want to avoid mycologic, if there is no good microbiologist available to do it, a dermatoscope can help you. Then this is a patient where you have to confirm the diagnosis because the only answer for this glomus is surgery. And X-ray is not very definitive. Earlier, we used to send this for MRI. But first of all, the cause. Secondly, many patients are phobic about entering a tunnel, and it does not pick up any growth which is less than 2 millimeters in diameter. So now we take help of high resolution ultrasound. And high resolution ultrasound can pick up the lesion and tell you the size of the lesion, location of the lesion, and it becomes easier for us to localize, confirm, and treat. And you can, in the same ultrasound, do a color Doppler, and it gives you the fact that it's a vascular growth. So this is going to help us if you have high resolution ultrasound, which has got a probe with a frequency of 15 to 24 megahertz and a hockey stick probe, not the round probe. You can pick up sometimes just zero point 0.2 millimeter growth also, which is much more sensitive than MRI. Then there's a patient who just has a single opaque thing. If I suspect fungus infection here, then this is a dermatophytoma. This is a biofilm of the fungus where oral medicines will not work because the fungus is sequestered inside in the colony where medicines don't reach. So to confirm the diagnosis, then do a debridement of this part to remove the nail plate mechanically. For example, this, you have to do histopathology. You can't be very sure without histopathology. So mycology, biopsy, so the mycologic studies which shows the trichomonas rubrum, you can see filamentous hyphae and spores. You can see this chain of hyphae, and you see the cottony colonies and Saboras dextrose agar. The final descent, I'm so sorry, this is not from my presentation. So with this, the final tips before I say thank you to you is, don't take the nails lightly. I know it's a neglect appendage, but we should all make a resolution to adopt this neglect appendage, examine it well, be better clinicians, and offer patients more definitive diagnosis. With that, I thank you and I conclude my talk.
Thank you so much, sir, for your wonderful presentation. We do have some question if you like to take that up.
Oh, sure.
So, sir, the first question is, how does nail health reflect overall nutrition status, and what additional tests should be considered when deficiency are suspected?
So first of all, whenever they show punctate, opaque white spots, the doctors casually tell the patient and the child's relatives that this is a calcium deficiency, which is not true. That is leukonychia. Most of the time, that is due to trauma or subtle psoriasis of the nails. A deficiency which is extreme will allow, like the hair, when we have extreme deficiency, What is not essential will not be supplied any nourishment, so hair shedding will increase. Similarly, nails will not grow well, they'll become thinner and brittle. That is how you can come to know soft, malleable, thinner, brittle nails not growing easily will give you an indication about deficiency. Otherwise, nails don't tell you so much about deficiency, and there's no change related to A or except for some cases of colonychia where you suspect iron deficiency.
Thank you, sir. The next question is, how can nail fungal infection serve as a entry point for further complication in at-risk population?
Yeah, so first of all, the fungulation of the nails, if not treated well, once you treat the skin, this is the reservoir of infection. Whenever they wear shoes and they sweat, and when they have on the fingers and scratch, the fungus in future will spill over from the reservoir onto the skin, and that may be one reason of recurrent fungal infection on the skin is when you've not treated the nail adequately, and that's a go down from where the supply keeps coming back. Secondly, that can cause the nail to become thick and difficult to trim sometimes, and sometimes that can lead to a trauma of adjoining part in old people who have spine issues, joint issues. They can't bend and cut, and they are left to themselves because of the modern scenario where kids are away in foreign countries. That can get embedded in the flesh, and that can cause an infection in uncontrolled diabetes. It can be one of the reasons why gangrene can set in.
So there is one last question. What additional investigation should be pursued when abnormal ridgeting is detected?
Abnormal
Ridgeting.
ridging.
Yes, sir.
So
Maybe.
first of all, when we see ridges which are along the length of the nail plate, these ridges are usually seen normally in people beyond the age of 45 and 50. So all of us beyond 45 and 50 will have some ridging. There is a sign of aging of the nails. And people go and get it buffed to make it look smoother. So ridging can be a part of multiple skin conditions. Psoriasis, lichen planus, but you can't look at the ridge and say it is so and so disease. You know, examine the skin and look for other signs of the disease. And sometimes when you feel that it will help, you can do a biopsy of the nail unit to find out whether you get any clues about those diseases if there are no skin lesions.
Thank you so much, sir. That's all from our audience. And thank you for answering all our questions. So, sir, before concluding, any take home message from your end?
I think I did tell them that take the examination of nails very seriously. Make sure that you use all the magnifying glass. Nails should be clean. You should have better light when you examine all the nails. And women should be told to show the nails because many times they come in for a skin issue. They say, Doctor, I also have some change the color of the nail. I said, where is it? But she's saying, I put a nail paint. You can't examine anything well with a nail paint on. So all those and a nail change of color, subtle change of color, as I showed you in a person who had pigmentation around the nail was malignant melanoma. So you can sometimes get not only brownie points by picking up a good disease very well, but you can diagnose it early and save somebody's life.
Thank you so much, sir, for joining us today. And with your permission, sir, I would like to conclude today's session. Thank you.
I would also thank you again. And I did finish 5 minutes before my time. I could have
Yes.
shown more images, but I thought so few images but good take-home messages are more important than showing many more conditions.
Thank you, sir.
Okay, thank you.